Hi, I'm Raja Ali Abdulnour, Director of Educational Innovation at the NEJM Group and lead physician on NEJM Healer, our upcoming clinical reasoning simulation for learning and assessment of diagnostic reasoning. I'm very excited to be here today on behalf of my co-authors to talk to you about this new project. As you all know, diagnostic reasoning, which is based on a well-established theoretical framework, is notoriously difficult to both teach and assess objectively. Here we've developed an application where we lay out the steps of diagnostic reasonings for learning to engage in a safe manner and a deliberate practice, which allows them to grow, learn, and also allows the educators to track their progress. The framework we used in the application is shown in Figure 1 and adapted from work by others, including Cross-Curry and Cathy. In the application, as in real life, diagnostic reasoning will start with data acquisition. The data is then transformed into a problem representation, which is a string of key findings. That problem representation is then used by the pattern processor to query an illness script memory bank. If a pattern is recognized, then system 1 is activated and the hypothesis is generated pretty quickly and intuitively. If a pattern is not recognized, then system 2 is activated, where a clinician spends some time digs deeper into textbooks or their own memory or diagnostic schemas to try to identify potential hypotheses. Once a list of hypotheses have been generated, a script concordance is done, where a physician compares and contrasts the different diseases in relationship to the results, as I show you later, and a differential diagnosis is formed. Once the data acquisition is complete, or a differential diagnosis is obtained with high enough certainty, then the learner either goes back for hypothesis-driven data acquisition, in the case of the former, or moves on to set a final hypothesis and a diagnosis and management plan if the latter. Items that are highlighted in a solid orange line are items that are currently assessed, whereas items that are highlighted in the dashed lines will be assessed in future iterations of our application. Figures 2, 3, and 4 are screenshots from the application in its current format. In Figure 2 is the history data acquisition section. Like all sections, a learner will be able to freely and organically query the patient and his or her chart for data. Whenever data is thought to be important or relevant, the data is selected, and which will be added to the diagnosis builder, shown later. Once the section is complete, before proceeding to the next data acquisition section, the learner needs to write a problem representation at the top of the screen here. Once this is done, the next step is to go to the diagnosis builder, which is shown in Figure 3. In this script concordance table, the results are aligned in the first column. The headers of the subsequent columns are where illness scripts are activated, either based on the problem representation and system 1 thinking, or through analytical thinking and going through diagnostic schemas. As you can see at the bottom of Figure 3, there's a knowledge center that learners can access where they can consult diagnostic schemas and expert illness scripts in case they need to. After activating illness scripts, the learners need to assign a likelihood ratio for each result in relation to each disease. They don't need to do it for every result, only for the results they think are important to them. The likelihood ratios are color-coded, where positive likelihood ratios are in red and negative likelihood ratios are in blue. The darker the red, the higher the positive likelihood ratio, and vice versa. As data is obtained, a likelihood meter at the bottom will convert or summarize or synthesize the likelihood ratios they've assigned in the case to the point where a lead diagnosis may be suggested. In any case, if a learner thinks the disease is lead, then they can do so by checking the right button. Once a case is complete, the case is submitted for a feedback, which is shown in Figure 4. This is a screenshot of the summary feedback, which gives feedback on lead and differential diagnostic accuracy, the first two items, problem representation concordance, where learners self-evaluate their problem representation compared to that of experts, data acquisition thoroughness and efficiency, and finally, illness script concordance, where we specifically look at the assignment of likelihood ratios in comparison to that of experts. They can enter each section for a breakdown of that feedback. And then at the top right, There's a summary in the bar graph currently of their overall clinical reasoning performance. That's it for now. We are currently in a pilot format. We are wrapping up our current pilot and analyzing the data, and we are moving forward with the beta phase where we can complete development. We are hosting an upcoming NEJM group workshop where we will be talking more about HEALER and the process of assessment and teaching of clinical reasoning. If you're interested in participating, please email us at the email shown here. We anticipate the workshop to occur sometime in mid-November. Thank you very much for listening, and I'm really excited to meet and talk to some of you at the meeting. Thank you.